competition altogether. If you're facing any difficulty with renaming yourself, you can always reach out to any of the hosts or the co-hosts, so they'll help you out. Over to you, Jatin. And we are live on YouTube, so I think we can kickstart. And all the very best to all the participants. And over to you, Jatin.
Okay. So since all the participants are here now, let us begin. Uh, so AIRPC 2.0, that's All India Research Presentation Competition. And yeah, so we have two judges with us here who will be looking over all the event. And yeah, Dr. Parag Chavla is one of our judges. And he's MD-PSM, CMCL, FIMER Fellow, and FIPSM. He's the Associate Professor in Community Medicine Department. He's also the Member Secretary in the Central Research Unit, and he's the coordinator of Student Startup and Innovation Cell at GMOS Medical College, Bhotri, Vadodara. And he's currently serving as a faculty at CMC Ludhiana, and he's also the coordinator at IAPSM eConnect platform. He earlier served as a member at the editorial board in the Indian Journal of Community Medicine. So welcome, Dr. Chavla. And the other judge is Dr. Monica. She's MD Community Medicine, DMB, and FCCD. She's the assistant professor in the Department of Community Medicine and also a member of the scientific committee and SMEOs, that is UG and PG research activity. And she's currently at the government Siddhartha Medical College in Vijayawada, Andhra Pradesh. So yeah, I'll just go over the event flow once again. So now all the participants will present. Uh, the first participant to present is Noor, followed by Dhruv, followed by Shreya, followed by Anam. I hope you all are ready, and best of luck to all of you. And each one of you will get 4 minutes to present, and which will be followed by 2 minutes of question and answer. So Noor, if you're ready, just unmute and let us know, and we'll start your presentation.
Hi, yes, I'm ready.
Okay, thank you, Noor. Just give us few more minutes. Dr. Parag and Dr. Monica, do you have any set instructions that you wish to give to all the participants? If not, then we can kickstart with the presentation.
Monica, madam, if I may.
Yes, sir, I'm here. I think we are clear with are the participants aware of the judging criteria? I think that much would be done because you have given them the instructions regarding 4 minutes of presentations and they have to stick to the time.
Yes. And Monica, madam, I just wish to clarify maybe if it can help the participants that since the time is very short, so give more time on the results part and methodology and spend less time on the introduction. So that will give us more time to understand what you did.
Yes, sir. I think the students have to majorly concentrate on the objectives of their study, the objectives with which they have made the study, and then stick with the methodology and results part. Give more concentration to these three parts of your slide. Rather than spending more time on introduction and conclusion, I would we would request you to concentrate more on these parts of presentations.
Okay.
Yes, thank you, Dr. Parag and Monica, for your valuable instructions for all our participants. With that, we'd also like one of our moderators to keep a check on the timer as well. And over to you, Jatin, to give a heads up to the first participant. Jatin.
Yeah, so Noor, if you're ready.
Okay, do I have to screen share?
No, we'll share the presentation for you. You just have to speak.
Okay. Hi, good evening, everyone. My name is Noor, and my research is on perceptions and solutions for workplace violence against doctors, an observational study in a tertiary care hospital. So just before starting, I wanted to mention that the reason I did this study was because a surgical resident in the hospital affiliated with my college was physically beaten up and had to be admitted. So that really led to me wanting to know more about this topic and the perceptions and solutions. So next slide. Workplace violence, according to the WHO, is an incident where a staff is abused, threatened, or assaulted in circumstances related to their work, and it involves an implicit challenge to their safety, well-being, and health. And this can include both physical and psychological harm. And because this is rampant in India, this necessitates not just a discussion, but also appropriate measures to combat the problem. Next slide. So this study is a cross-sectional questionnaire-based observational study, and the 3 hospitals affiliated with my college are Lok Naik Hospital, GB Pant, and Guru Nanak Eye Center, and a total of 172 healthcare workers participated in this study, which include interns, residents, postgraduates, and senior residents. And there were 4 sections in the questionnaire: demographic details, type of violence that they faced and the frequency, analysis of the factors and perceptions, and the proposed solutions according to them. Next slide. So workplace violence was found to be widespread, and 88.9%, which is 153 out of 172 respondents, said that they faced workplace violence, and a total of 77.3% faced verbal abuse. Can you just click so that the graph comes? Yes. So as you can see, verbal abuse was slightly more, it was in medicine, 90.2% faced verbal abuse at a time. And whereas in surgical departments, 89.5%, and more than 90% doctors reported that emergency was the most workplace violence prone setting, as you can see in the second graph. Next slide. When it comes to analyzing the factors that were responsible for causing workplace violence, so the healthcare workers said that in the questionnaire, almost 80% of them spent less than 10 minutes with the patients. And as you can see in the first graph, a lot of them spent even less than 5 minutes. So they think this could be a factor. And the second graph shows that how medical residents, only 4% have never or seldom lost their temper while dealing with the patients. Next slide. So now the most effective measures, according to healthcare workers, to combat this problem was, so to limit, to have a one patient and one relative approach, according to 81.98%, this was found to be extremely effective, the first graph. Yeah. And increasing the number of doctor duty rooms was found to be very to extremely effective by 77.43%, and recruitment of marshals by 74.42%. Next slide. So now to conclude, so workplace violence in India is comparably higher than it is compared to other countries. And the factors that are contributing to this are working in emergency settings, early career, for example, postgraduates as compared to senior residents, then patient characteristics such as complicated cases, non-compliant patients, then improper functioning of the 3-tier system, lack of triage, lack of facilities, and another, as evidenced, medicine and surgery reported a much higher rate of workplace violence as compared to paraclinical departments. Next slide. So just the limitations of my study were that because this was a questionnaire-based study, there could have been recall bias. Second, I should have compared the relation with working time with the workplace violence, because different departments have different working time. And lastly, because my hospital is a government hospital which provides free of cost care, so there is a really high patient load, immense workload, and lots of patients come presenting in serious conditions. So that could have been one reason the study showed higher workplace violence. Thank you.
Thank you so much, Noor, for your lovely presentation.
Mhm.
So, with this, we will also be for the upcoming participants. We will also be playing a sound which indicates the end of your presentation, the speculated time, and with this, we'll be going to the judges. Over to Dr. Parag and Monica.
Uh, yeah. Hello, Noor. Congratulations on successfully completing this study and completing in time your presentation.
Oh, thank you.
I have one question. Yeah,
Yeah.
I have one question. You were suggesting that some measures were effective. So I assume that those were the suggestions that your participants gave to reduce the workplace-based violence. And within the scope of this study, you did not check the effectiveness of those suggestions, right?
Yeah, yes, sir. Like we actually discussed with some of the residents, and we made like a list of solutions, and then we
Okay.
had them like assess what they think is most effective.
Yeah.
So, for example, they found some more effective than others, and the ones I listed were the ones they found most effective in the list.
Perfect. Perfect. Okay. So thank you, Noor. Thank you.
Thank you so much.
Yeah. Hi, Noor. That's a very good presentation, and you have finished on time. That's really appreciable. I just have one question and one suggestion to you.
Yes.
My question is, how did you define what's the operational definition you have given for workplace violence?
So like workplace violence, as you know, like it's a very vast term, and there are like
No,
different.
you have the WHO definition. I accept
Yes,
with
yes,
it. We
yes.
should always have a definition called operational definition. I mean, how did you
Okay.
ask to the participants?
So like in the research paper, we had like different things, like it ranged from verbal abuse to physical and sexual assault to threats. All of that was taken into consideration
So you
while
have all
making
the
the questionnaire.
components in your questionnaire, and
Yes,
if
yes.
any participant satisfies with any of it, you have marked them as facing workplace violence. Is it so?
Yes, yes. But I only
Okay.
highlighted 2 or 3 to keep the presentation short, because like
Okay.
some things like verbal abuse were the most common as compared to like let's say like any like stalking or things like that.
Okay.
That's very like rare
Okay.
comparatively.
And my suggestion was the numbering of graphs was not correct. So
Okay,
next time, anytime you make a scientific presentation, concentrate on numbering of it, titling of it. So just concentrate next time. Okay.
okay, okay. Thank
Yeah,
you.
it has to be in a chronological order, and there was some sort of disturbance in the numbering of it.
Okay,
Okay.
okay.
Yeah.
Thank you so much.
Fine. Thank you.
Thank you.
Good presentation. All the best.
Thank you.
Okay, great presentation, Noor, and thank you both the judges. We'll
Before we
now
go on, just a second, Jatin. Before we go on to the next presentation, I'd like to just this would be the sound you hear when 4 minutes are up. I hope that's audible. So just letting it's not.
No, Janelle, it wasn't audible. If you could play it from your phone.
That's okay. Just give me a second. Is this audible, or should I try something else if that's not fine?
no, it wasn't
No, we
audible.
weren't able to hear.
Okay, give me just a second.
Yeah.
Can you confirm?
Yes, it was audible. Could you play it again for one last time?
We good to go? Neil, if you could please confirm.
No, we couldn't hear the second time. So
I'll try to share my audio.
if you're facing difficulty, then I could play it for you.
If we could do that, that would be good. I'll try to fix it by the next one.
Okay, so the sound would be this. I hope it's audible. If confirm.
Could you play it again?
Is it audible? Okay.
No.
Wait, I think I can fix it. Just give me a second. Was that audible? Still no? Okay. If the participants could just open the chat box on their Zooms, then we'll be commenting as to when their time is up so that we can initiate with the presentations, please. I think we can go ahead.
Okay, so the next participant is Dhruv. Are you ready, Dhruv?
Yes, I'm ready. I just wanted to confirm if I'm audible here.
Yes, you are.
Perfect.
Can both the judges hear Dhruv?
Sorry.
I just wanted to confirm with the judges. Is Dhruv audible?
Yeah, he's audible.
Okay.
I just got a sound. I'm so sorry for cutting you, and I hope this is audible. Okay. Yes, Jatin, we can start.
Okay. So Dhruv, if you're ready, we'll begin.
Yes, I'm ready. Yeah, so very warm good evening to everyone. I'm Dhruv, I'm an intern, and my project was about a quality improvement initiative in our NICU for improving kangaroo mother care practices for low birth weight babies. Next slide, please. Next slide. So let's know what kangaroo mother care is very briefly. It's a way of providing care to low birth weight babies, and it involves early, continuous, prolonged skin-to-skin contact between the mother and the baby. And it has benefits like preventing hypothermia, promoting breastfeeding, reducing infections, and overall outcome of the baby in terms of growth, especially in case of low birth weight babies. Next slide. So why this study? So who recommends that KMT should be done for as close as to 24 hours, which is not practically feasible. But if we consider doing KMC for continuous 6 hours, that is significant. But despite its known benefits, its practice remains suboptimal at most centers, including ours. And therefore, this QI project was planned wherein we aim to increase the KMC duration by at least 60% from the baseline. And the secondary objective was to promote breastfeeding. Next slide. So methodology, it was a simple QI project wherein baseline data, a QI team was made. It consisted of healthcare workers of different levels in terms of on-duty NICU nurses, intern, consultant pediatricians, and baseline data was collected on existing KMC practice, and a fishbone analysis was done to identify the existing barriers in our setup. And possible QI interventions were planned, prioritized by the above mentioned QI team, and interventions were planned through 3 PDSA cycles. So just to give a brief timeline, first week was collecting baseline data. Next 6 weeks, we ran 3 PDSA cycles with each with a new intervention, and the last 2 weeks of the study were post-implementation sustenance phase. Next slide. So this is the fishbone analysis, and wherein we had identified policy, process, people, and plan factors. Lack of postnatal counseling, not fully optimizing use of KMC chair, mother unaware, heavy workload, no participation of consulting doctors, KMC breastfeeding as the same entity, and things like that. Next slide, please. So in the first PDSA cycle we ran, it was focused on lack of documentation of KMC, and which was ensured by attaching this case record, KMC case record sheet to the NICU monitoring sheet, which was already there. And through this, we ensured robust documentation of KMC and increased the KMC hours from baseline 3.5 hours to 4.3 hours per baby per day. Next slide. The second PDSA cycle, we incorporated formal postnatal counseling to mothers. These are the snapshots from the IEC material, which was flip charts, which were circulated in the NICU and even displayed there 24/7, through which we could increase the duration to 5.8 hours per baby per day. Next slide. Third PDSA cycle gave the maximum boost to KMC to 8.5 hours, wherein here we made certificates of appreciation to mothers who are consistently giving significant KMC to mothers, to the low birth weight babies. And the certificates were handed out by on-duty NICU nurses. Next slide, please. So overall, in the results, we can see in the run chart, while the PDSA cycles were being run, the duration was going up from the baseline 3.5. But in the sustenance phase, there was around 30% drop in KMC duration. Next slide, please. So identifying barriers is essential, and simple QI steps can help us with that. But drop in KMC sustenance can be attributed to people factors, plant factors, the 30% drop which we could see, and this is an hypothesis, and the people factors, the lack of felt need and motivation, and the heavy workload, severe cases. And the next slide, please. So maximum boost to KMC was given by PDSA cycle 3, wherein we handed out certificates of appreciation, and sustainability was identified as a challenge. So what better can be done is maybe increase the PDSA cycle duration and include consulting pediatricians to prescribe KMC like any other NICU medication or procedure. And appointing a dedicated KMC nurse in NICU. That's it. I'm sorry for exceeding the timeline. I would welcome questions from the judges.
Thank you, Dhruv, for sharing your research work. It is interesting to note some action research being presented, and it's wonderful to see the results. I have one question for you. What was your role in this particular research? Just wish to clarify whether this was a project which was initiated by a faculty and you participated as one of the team members, or was it your own idea and you began a concept designed and conceptualized the entire project?
It's the latter. I went up to the guide and suggested that we could do something about this. And I was the one who made the QI team and was a part of it as well, the quality improvement team.
That's wonderful. And so whose idea was to do the PDSA cycle?
That was my guide. She suggested we can run around 3 PDSA cycles over a month.
Okay, thank you, Dhruv.
Thank you, sir.
Yeah, congratulations, Dhruv, on your work. I was really impressed to see some of the practical things there. It was really nice. But even my question was that I was also interested to know what's your contribution to this research activity, because it's really good. If you are participated in this work, I think it's appreciable. And I don't have any questions, but I have one suggestion actually. The results part, I mean, you've kept a lot of information in it. So I think for the time constraint and all, when you're presenting a scientific presentation like this, you have to concentrate on time part. Apart from that, I think that's a beautiful work which aims at reducing the MMR and IMR. I think that's really good.
Thank you so much, ma'am. So just to briefly mention about the question you asked. So my role was to draft the certificates of appreciation and also the IEC material which was circulated. We made them from scratch from WHO documents, and even the there was this document from Government of India as well, wherein KMC was mentioned. So we made this IEC material for a formal postnatal counseling within the NICU, and it was circulated and used for one-to-one postnatal counseling for all eligible mother low birth weight babies diets.
So you have considered, within a duration of time, you have considered all the mothers of low birth weight babies for this study?
No, ma'am.
Did you have a sample calculated?
We did not have a sample calculated. We wanted to include as maximum enrollments as possible in the 1 month study period, and only stable low birth weight babies who do not require any NICU intervention per se were considered. Only the stable babies were considered for this study.
So that keeps you restricted your results to your sample only, isn't it?
That's right.
Yes. Okay, that's fine. Thank you.
Thank you.
Okay, so the next participant is Shreya. Are you ready, Shreya?
Yeah, hello. Am I audible?
Yes, yes, you
are. Can I start?
Yeah, if the judges allow. Should we move ahead, judges?
Yes, please.
Okay.
Good evening, everyone. I'm Shreya Tadigotla. Today, I'll be presenting my paper on urinary alpha-1 microglobulin as a marker of nephropathy in type 2 diabetes mellitus. Diabetic nephropathy is a serious complication of long-standing diabetes mellitus that can lead to mortality, cardiovascular diseases, and end-stage renal disease. It occurs in about 20 to 40% of the patients with diabetes mellitus. Currently, microalbuminuria is used as an early marker, but it can also be which can be associated with exercise, UTI, and acute illnesses. In most patients, microalbuminuria can occur after significant renal impairment. So urinary biomarkers like alpha-1 microglobulin can be used as an inexpensive and non-invasive diagnostic tool for early detection of renal damage in diabetic patients. So as the incidence of diabetic nephropathy differs among populations, and it's also dependent on genetic factors, it's crucial to study nephropathy in Indian diabetic subjects who are at a higher risk of developing it. The aim of the study is to determine the role of urinary alpha-1 microglobulin level as a marker of nephropathy. The objectives of the study are to estimate the alpha-1 microglobulin levels and the albumin-creatinine ratio, and also to study the relationship between alpha-1 microglobulin level, albumin-creatinine ratio, and the eGFR. Next slide, please. It was a cross-sectional study which was conducted on random urine samples of 72 subjects with type 2 diabetes mellitus who were aged between 18 to 65 years with a HbA1c between 6.5 to 10%, and they were on routine follow-up. The subjects were grouped as diagnosed with type 2 diabetes mellitus for more than 5 years and less than 5 years. A written informed consent from the participating subjects was taken, and ethics approval was sought from the Institutional Ethics Committee before the initiation of the study. This project was approved and funded by the ICMR. The alpha-1 microglobulin levels were estimated using ELISA. Next slide, please. The descriptive statistics were analyzed with the help of mean and independent t-test was used to compare between the groups, and a Pearson correlation between study variables was done to study the relationship. From this, we can know that both the groups had almost equal number of males and females, and the mean age of the population was around 58 years. Next slide. Next one, please. From this table, we can know that the alpha-1 microglobulin, okay, next slide, please. The urinary alpha-1 microglobulin creatinine ratio was increased in both the groups, but a higher increase was seen in the second group. So from this, we can know that the subjects with longer history of diabetes were found to have greater levels. Next slide. In group 1, the albumin creatinine ratio was within the normal range. However, in the group 2, it was raised. So from this, we can understand that even in subjects with normal albumin levels, there was an increased urinary excretion of alpha-1 microglobulin. And we can also see a positive correlation between urinary alpha-1 microglobulin and the albumin creatinine ratio. Next slide. We also observed that with the decline in EGFR and urinary creatinine, there was an increase in alpha-1 microglobulin creatinine ratio, and it was significantly, it was very significant. Next slide. Next one. Next one. Yeah. Also, while comparing the urinary alpha-1 microglobulin ratio with HbA1c, fasting blood sugar and postprandial blood sugar levels, we could see that urinary alpha-1 microglobulin levels were higher in patients with poorer diabetic control. Next slide. Yeah, from this, we can conclude that urinary alpha-1 microglobulin can be used as an effective marker in early detection of renal disease and type 2 diabetes mellitus. We could also see that a significant increase even in patients who had normal albumin levels. Moreover, the severity and duration of diabetes can also be related to the urinary alpha-1 microglobulin levels. And it also showed an increase with a fall in EGFR and urinary creatinine. So from this, we know that this can be used as a more effective and timely interventions to prevent the progression of renal disease in individuals with type 2 diabetes mellitus. Thank you.
Thank you so much, Shreya, for your presentation. Judges, do you have any questions for the participant?
Thank you, Shreya, for coming up with a study from the basic sciences. It's interesting to know about this particular study. I have two questions. One is that who funded for the ELISA testing for this particular study? Is it part of the routine at your hospital setting? That's one. And second is the way that the results have been presented. It's little longer, and so you found it difficult to complete within time. So if you were to simplify, maybe tell us the conclusion in one or two simple statements. Probably it will help us understand what the study concludes. At the end of it, what did you find? So those are the two questions.
Okay, so as far as the first question is concerned, the ELISA kit was funded by the ICMR grant money from the SDS. And it's not done as a routine as of now in any of the hospitals. And the second question, so the major findings from this study is that we could see that urinary alpha-1 microglobulin was increased in subjects with diabetes mellitus, irrespective of the duration of diagnosis, indicating that there has been some changes in the kidney. Also, when we usually microalbuminuria is used as a marker for early nephropathy. in this case, there were the group 1, which is subjects diagnosed with diabetes less than 5 years. So they did not have microalbuminuria, but then they had a rise in alpha-1 microglobulin levels. So this suggests that we could use alpha-1 microglobulin to test and detect early nephropathy even before the albumin levels are increased in the urine. We also could find a correlation between urinary alpha-1 microglobulin and urinary creatinine levels. And we even with the fall in GFR, we could see the microglobulin levels increasing. And also there was to some point, urinary alpha-1 microglobulin levels were increasing with increase in HbA1c, fasting blood sugar, and postprandial blood sugar. So this suggests that with poorer glycemic control, there could be higher chances of nephropathy. So,
Shreya, I'll finish quickly. Just one suggestion. If you are asked to summarize in 1 or 2 sentences, you have to finish in 1 or 2 sentences. That's the point that you can note for all your future presentations. Thank you. It was a wonderful study, Monica ma'am.
thank you, sir.
Yeah, Shreya, that's a good presentation, and the results are too robust, man. For the objectives, I think you need to stick with your objectives. Whatever the results you got for those objectives, you have extensively presented whatever you have found in your research, but that is fine. If the time would have been good, it would have been fine. I just want to know, did you exclude anyone? Are there any exclusion criteria for your study?
Yes, ma'am. We have excluded patients with any chronic liver diseases, chronic kidney diseases, and pregnant women, and type 1 diabetes, and also any acute illness.
So all the CKD patients you have obviously excluded.
Yes, ma'am.
Yeah. And what is the amount? I mean, I just want to know the implications of the study. For microalbuminuria testing, how much would it cost? For alpha-1 microglobulin testing, how much would it cost?
Ma'am,
patient.
using the ELISA kit that we got, we could get around 90 samples for around 40,000. I mean, sorry, 25,000, ma'am.
25,000, 90 samples.
Yes, ma'am.
Okay. For microalbumin, how much would it cost?
Ma'am, it's way cheaper. I think 100 or within 200 per test, I think.
So you are telling another costly tool for a patient to have an early diagnosis of nephropathy. Is it so? Obviously, the microalbuminuria is way cheaper than alpha-1 microglobulin. Is it so?
Yes, ma'am.
Yeah. Okay. Fine. Okay, that's a good work. But restrict yourself in the results part alone. Okay, next time. But the way you presented the results, that and all, for a publication part, I think it's very good on your side to have such good extensive results. But when presenting, I think you should restrict. All the best.
Thank you, ma'am.
Okay, now moving on to the last participant, that is Anam Fatima. Anam, are you ready?
Yes, I am ready. Am I audible?
Yes, you are. Before you start, I'll just like to once more request you to please respect the time limit. That is 4 minutes for your presentation, and also in the question and answers by the judges. And yeah, we can begin now.
Good afternoon, good evening, everyone. My topic is evaluating knowledge, practices, and utilization of healthcare services among high-risk pregnant females in an area of diversity across sectional study. Next slide. Almost 15% of pregnancies are always at risk of developing complications that might threaten the maternal and neonatal mortality. Among the most common risk factors for high-risk pregnancy are gestational diabetes mellitus, anemia, and pregnancy-induced hypertension. So, in order to minimize the maternal mortality rate, Government of India introduced the concept of ASHA, which we call Metanin in Chhattisgarh, under NRSM, where schemes were introduced in the benefit of pregnant women, and RCH portal was designed for early identification and tracking of pregnant women registered with ANM or ASHA. Next slide. So the objective of my study was to determine the knowledge, prevalent practices among high-risk pregnant females, assess the utilization of healthcare services among high-risk pregnant females, and track and validate the data obtained from RCH portal. Next slide. So this study aims to evaluate and understand the shortcomings both on the part of pregnant women as well as healthcare providers. Next slide. So this was a cross-sectional observational study. Purposive and quota sampling was done through data obtained from RCH portal. Study population was 109 pregnancies registered as HRPs on RCH portal, and data was collected using self-structured questionnaire using interview method. This study was conducted in duration of 2 months. Next slide. Okay, the inclusion criteria was from 4 to 8 months of pregnancy. High-risk pregnant females were included. Next slide. So there was a shocking observation which came into highlight that only 48.7% high-risk pregnancies could be tracked from the data obtained from RCH portal. 51% females did not know about their complicated conception, because they did not know about their high-risk pregnancy status. Next slide. So the cause of high-risk pregnancy could not be assessed in 22% cases. This was cross-matched with the prescriptions they have, and with the ANM or ASHA, the cause of HRP could not be assessed in 22% cases, and the most common cause we found out was anemia. Next slide. So there were some positive findings as well, like 92.5% high-risk pregnant females followed the recommended agency visit, majority registered at an Anganwadi center, and majority took an IFA tablet, while only 15.1% knew about the danger signs of pregnancy. I think it is not clearly visible on this PPT. Okay, next slide. So only 13% females knew about antenatal exercises and practiced it. This is all got mixed up. Can I just screen share? Okay. Okay. So we evaluated about the Kilkari services. Only 7.5% females knew about Kilkari services, and only 62% females were aware about the government scheme. Next slide. Majority had a MCP card, and majority registered their pregnancies first semester. Next slide. So utilization of healthcare services among majority use the government healthcare services. Among those who use private healthcare services, majority found the government services to be unsatisfactory. Next slide. So in terms of the cost incurred while using a government service, 24.5% incurred a cost while using a government service, out of which maximum incurred cost while transportation. Next slide. So the antenatal services received at the government health clinic, you can see the HIV and STD testing has only 77% females received it, while majority of services were delivered to the females. Next slide. So in terms of interaction with the ASHA during pregnancy, only 1.9% did not interact. And when they were asked about any difficulty they encountered while during their pregnancy, so they gave first preference to contact the ASHA. Next slide. So among advices received from ASHA, very few receive advices on Kilkari services. Next slide. So in conclusion, next slide. So this study assesses the ground realities of a healthcare system. There is a need for reforming information, education, communication among pregnant women through health talks and counseling sessions. Timely upgradation of the RCH portal needs to be done to maintain the credibility of the data As we can see, only 51% of data could be tracked using the data could be tracked from the RCS portal. So this is a very shocking thing, because in the future, if we need national statistics for high-risk pregnant females, the first thing we will go for RCS portal. So uh, credibility of the data needs to be maintained. Next slide. Okay, I would like to finish here on this. Thank you.
Great presentation, Anam. Judges, we can move ahead with the question and answer round now.
Yeah, thank you, Anam, for taking up an operational research from the field. Uh, I have just one suggestion to Anam. If you can make the research question a little more focused, probably it would help the audience also understand. So, say for example, this operational research is done to feed into the policy, right? So, if you were asked to present this in front of the collector of the respective district, and if collector asks you to summarize whatever your findings are in 1 or 2 sentences, you should be able to do so. So that's just a suggestion. Because you have studied a lot many questions, it may not be necessary to present information of all of your research questions that you ask. You can choose to prioritize few, which are your key research questions based on your objectives. That's just a suggestion. Otherwise, wonderful to come across an operational research study from the field.
The PPT was not clearly visible, so the findings were not seen. So, it
We
would have been
understand that.
better.
Yeah, and that's fine. That's fine. That happens.
Thanks, sir.
Okay, Anam, that was really good. Congratulations on your project. As Sir mentioned, even I was impressed to see at a UG level and operational research in the field level. I was also very impressed. But yeah, as Sir suggested, my suggestion also would be with the presentation part, you should restrict yourself to the strict objectives. So the objectives, whichever you have mentioned, you have to take care that that is mentioned in the results part. And as I've already spoken to the previous presenters, you should always number your graphs or number your tables, so that if at all we want to ask go back to table number 1 or go back to graph number 1, that would have been very easy for us. So it's a suggestion to all the students whoever have presented, always number your tables, number your graphs, number your slides. That is a very must in any scientific presentation. Apart from that, pertaining to your study, I think there are no questions from my side. It's all presented. Thank you.
Thank you, ma'am. I'll keep that in mind. Next time.
Okay, thank you so much, judges. It was a really great event up till now. So now we're going to have a break for 5 to 7 minutes, during which the judges will come up with the results for this competition. The break will be followed by the participants sharing their thoughts on the competition and the presentations of other participants, which will be followed by the announcement of results, and then the judges will speak a few words about the competition, and we'll then conclude the session. So it is 6 now. We'll meet back again at 6:07. So that's 7 minutes past 6. So yeah, we can reconvene in 7 minutes.
Sir, I think, would you like to tell them the results, sir?
Yes, Monica, madam. I guess Jainil has declared a 7 minutes break, which is completing at
Okay.
6:07.
Okay.
Jainil, do we wish to
So,
resume?
yes, we'll resume in just a minute. I think Jatin will take over. But before we share the results, we'd like to ask the participants to share their experience of this competition. So, Jatin, can you please facilitate that?
Yeah, if all the participants are here, I guess we can start them. You can just unmute and let us know, all four of you. Anam, Noor, Dhruv, Shreya, are you there?
Yes, I'm here.
Okay, Shreya, Anam.
Yeah,
Yes,
I'm
ma'am.
there.
Okay. Okay, I guess everyone's here. We can start. So, yeah, before announcing the results, we would like to ask the participants to share their views on the competition and maybe their opponents or their other participants' presentations as well. So, if anyone would like to volunteer.
Can I go ahead?
Yeah, sure.
Thank you so much for having me for this lovely event. To keep it very simple, this event was really insightful in terms of so keeping in mind all the presentations which happened today. It was really insightful in terms of being a good learning experience, like keeping in mind those minute details, like sticking to your objectives, labeling your diagrams, graphs, keeping it very well and things like that. So it was more of I'm really happy to be grateful to be a part of this in terms of a learning experience. And thank you, Monica ma'am and Parag sir for judging, being the judges for today evening. Thank you so much. And I would love this even more if it would have been offline rather than on a Zoom platform.
I would agree with this point. Thank you so much for giving me this opportunity to present my research in front of all of you. Thank you, Parag, and thank you, Monica ma'am, for this opportunity.
Hi, yes, I agree. Like this was a great learning experience, and I actually have like real like fear of speaking, so I'm actually like surprised. I'm just happy that I took part, and I really loved listening to others' presentations as well. It was really insightful. Thank you.
Noor, since you expressed your fear, let us share that you have a lovely, beautiful voice, and it's only then when you're expressing that you had some fear of public speaking, we got to know. When you presented, I mean, there was no way that someone would sense that you had such a fear. So your presentation in that sense was absolutely flawless. There was no issue at all that we perceived that there was anything which was lacking or you did not have sufficient confidence. We did not perceive anything of that sort at all. So you came across very confident. You knew about your facts, and your presentation was good. It was sorted. So take that as a feedback. It was wonderful listening to you.
Because my like watch showed my heart rate was over 130, 140 before my presentation started.
Yes,
Yeah,
I
that's
accept with Dr. Parag. You portrayed yourself very well, dear. So that's a very good step from your side.
so. Noor, let me share that. Say, for example, I have 10 years of professional experience after passing my MD. Whenever I'm speaking in public, my heart rate also goes up. That's very natural for anyone, because we feel that all of us are, let's say, intelligent audiences, and then whatever we speak, we should not be wasting their time. So that's very a natural, normal response. So if that happens, let it happen. That's what we call as eustress. So that little amount of stress has to be there, that keeps us going. Wonderful, Noor. Thank you.
Okay, I guess every participant has spoken now, and one of them is having trouble unmuting. So we can move ahead with the results if the judges are ready.
I'll request Monica madam to announce the results.
Oh, sir, thank you for giving me the privilege. Yeah. By the way, I congratulate the organizers to having this great opportunity for the students to present their extensive work on the research. And as an undergraduate also, it is definitely important to know the basics of research methodology, how to do it, how to imply it. So I think that's a very great initiative from this organization. So, sir, shall I go ahead and present the results?
Yes, madam.
Yeah, so with the discussion with the other judges, we too obliged by telling that Dr. Dhruv, he has secured the first place in these presentations, followed by Noor, and the third place to Shreya. So that's the place by which we got. First is Dhruv, second is Noor, third is Shreya. And Anam, you have also done very well, but obviously there has to be places, and this is the numbering. Don't lose any hope. So you have also done extensively well. And congratulations to the winners.
Thank you, ma'am. I'll take that in mind next time.
Thank you so much.
Thank you so much.
Yeah,
for
Noor,
that.
I think you should also participate in music side, apart from academics.
Thank you so much, and congratulations to Dhruv and all the other participants.
And I really hope that this opportunity is just a start for everyone, including all the other participants in terms of research.
Yes,
And
so the role of
this was
all
my
you winners is to motivate your colleagues, juniors, to take part in research activities of your respective colleges, and also your colleagues from other colleges. So that's on your shoulders now.
Definitely. Thank you so much.
I just, yes, ma'am.
Yes, sir. I want you to speak. You motivate them much more better than me.
Arey, ma'am. So, in fact, congratulations to all the speakers. It's wonderful that when the students come up with studies which are very rooted in real life studies. So, coming from basic sciences, or from the community medicine field, or from the hospital settings, which are action oriented, result oriented, and really very practically relevant. So, that's a very good experience that I'm having. Pleasantly surprised that students are doing meaningful research, not only participating in research, but doing research which is meaningful. So I'm happy to have participated here. If someone can quickly suggest from among those who presented, what do you expect? If you can share some of your expectations, say for example, from parties such as MSAI, what they can be doing in further, because you have some experience of doing research and then presenting it through this platform now. Would you wish to share some of your expectations कि MSAI ने क्या करना चाहिए, or anything that comes to your mind about the future directions?
If I may go ahead. In terms of what more MSAI can do, I think I'm not sure agar hoga for offline events, then I'm not aware about that. But if an offline event would be there, it would be really like, I'm not criticizing anything. I'm just it's my just the thought that an offline event of on a maybe a larger scale. I know it's difficult to organize and everything. And I think MSI is doing already, the standing committee on research is doing a lot of work here. as far as the international and the research exchanges and workshops are concerned. So I'll be very honest. My first motivation was in second year of MBBS when I attended one of the MSAI workshops on research organized by the SCORI. I just wanted to share that. So from that, it all started building ki research karna hai, karna hai, karna hai, karna hai. So that is how I wanted to just share this.
Thank you, Dhruv. And that's it. Thank you for that suggestion. And that's it from my side.
We're
Even
very
I
glad to
completely
hear that.
accept with Dhruv. I think, if possible, an offline session would bring up much more interaction among all of us. So, if possible, if there is any feasibility, even I accept with Dhruv.
Okay, we are very glad to hear that, Dhruv. And yeah, we also wish that we could conduct this offline. But and we always try to do offline things as much as possible. But since it's a pan-India organization, it is there are a lot of difficulties. I'm sure you understand. But yeah, it was a really great competition throughout till now, and all of four of you presented excellent uh, presentations. All of your researches were really great, and congratulations to each and every one of you. And yeah, we now also have the national officer on research exchanges, Kritika Malik. She's just joined the call, and yeah, she'd like to speak now, and I'll hand over the mic to you now, Kritika.
Thank you, Jatin. Thank you, guys. I'm so sorry, first of all, that I could not join. I was not well and I was getting a drip in the hospital. Yeah, that was the only reason. I'm really sorry. I was very excited for this event, but I could not. But I know I have been kept updated by my assess about how it went. And I'm glad that you people enjoyed and it was amazing. And congratulations to the winners. But I personally believe that anybody who participates has that courage. The person who has the courage to speak up, who has the courage to participate, will win one or the other day. So there's nothing as a winner or a loser, but it's just that somebody's a little better, somebody's a little less, maybe not the day or something like that. So don't get disheartened in any way. And regarding the offline events, we do have offline events, but there is definitely limitations to that. We would have our offline workshops for SCORI in the first week of May, 4th, 5th, 6th, 7th May in Nasik, where we will definitely cover a lot of topics on research this time as well. And this time we have even increased the amount of like exchanges. SCORI consists of both research and exchanges. So this time we are planning to have more of research topics as well as exchanges. Like combined, we'll have parallel sessions for research as well. So definitely the late bird registrations are open right now. So if you haven't registered yet, you can go there, register. And yes, I'll be there. I'll be one of the trainers. We have other amazing trainers, and you'll definitely enjoy. Looking forward, whosoever can come and join us in Nasik, it would be great. Even the people who are watching it live on YouTube, the late bird registrations are open now. You can register, not just SCORI, for any of your, what do you call, interest workshop. Yes, so yeah, I'm promoting NGA, but that's true, because offline events definitely have a different vibe. The way you connect amongst the participants, the way you understand, the way you just the the activities that we do, like it's never like you're just sitting. You'll be running around doing activities. There would be activities where you have a lot of things. It won't be a passive learning. It would be definitely active learning, and you'll gain a lot of insight on various topics of your choices. And thank you so much, Monica ma'am and Parak sir. I'm so sorry if I'm pronouncing your name incorrect, but thank you so much. It was glad. We are really honored that you accepted our invitation to be the judges for the event. Thank you so much for cooperating, and thank you so much for suggesting all the changes that you did and actively participating and suggesting things that you wanted to just make the event a lot better. All these suggestions we'll definitely implement again next year, considering we have this every year. So we'll definitely make sure to what do you call execute and add in the points that you have mentioned for the next year as well. Thank you so much, everybody. I think we can stop the live stream now.
Yes.